Hi everyone, me again, it's William Bradley. I apologize. This is going to be a slightly different recording to what everybody came to yesterday, but unfortunately with the recording we had some technical issues and the file that was downloaded was corrupted. So I'm having to record this session again in the very early hours of the morning. So I apologize if I don't do as good a job of it, and it will be slightly quicker because I won't wait for the polls or anything. So maybe a slightly quicker way to go through everything. So just going through the questions then. So question one, a 75-year-old man presents in your GP practice with middle back pain that is present throughout the day. He has also noticed some weight loss and urinary hesitancy. Some bloods are done. What result is most likely useful for the diagnosis of this patient? So the correct answer here is B, hypercalcemia. So as you can probably tell from my question and based on how correct most of you got this last night, the pathology that I am trying to heavily imply here is bony metastases secondary to prostate cancer. Prostate cancer is the most common cancer to cause bony metastases, and the location of these bony metastases is most commonly in the back. So this is a very standard presentation for these kind of patients. So looking at the vignette, it's talking about middle back pain. That is a big red flag for malignancy, just because that area of the back is less mobile. You get less like orthopedic damage from repetitive movements. It's more likely that happens in the lumbar and cervical spine. Any middle back pain, you instantly a little bit more concerned that it's going to be a more suspicious pathology. That on top of the obstructive urinary symptoms of hesitancy would lead you to believe that there's some sort of obstructive pathology in the urinary system, and putting two and two together, you can assume that there's some sort of prostate malignancy which has caused bony metastases. Now, with regards to the answers, I know a lot of people went for PSA of 4.5, and I can totally understand why you've done that. It's a relatively high PSA reading. Unfortunately, as PSA generally increases as men get older and older, 4.5 in a 75-year-old is actually considered a normal PSA. Anything under 5 in 70 and above patients is considered normal. Moreover, a high PSA in this patient wouldn't be indicative, wouldn't be, I mean, it'd be helpful in kind of giving you an impression of the diagnosis, but it's not a very specific or sensitive test, it's not going to actually aid in making the diagnosis. For making the diagnosis, you'd more likely see hyperkalemia. Actually, having since done the presentation, there have been a couple of questions whether or not bony metastases as a result of prostate CA are osteoblastic or osteoclastic in nature. There are a couple of mixed sources on the matter, so we're not totally sure if this is the correct answer, but from the sources that I have read, bony metastases cause breakdown of bone and hyperkalemia, but I will double check this and get back to everyone. As far as bony metastases go, you also get a high ALP, with that. So a low ALP is wrong. ALT is to do with liver pathology, and CA125 is most commonly used in the diagnosis of ovarian cancer. Okay, and this was just a nice little image explanation. It's a sort of PET scan, and you can see on this all of these areas, focal increasing density, where you have bony metastases. Okay, question 2. A 55-year-old man presents to A&E with shortness of breath, a dry cough, and reduced appetite, progressively worsening over the past 6 months. A CT chest is performed, which shows a central mass. You feel the most likely diagnosis is lung cancer. Which blood test is most likely to be raised in this patient? So again, this is a pretty tough one, and I apologize because a lot of these questions are pretty tough, but I quite like testing you on the tough concepts so that when you come to the easier topics and exams, you get more of them right. So don't expect to do overly well on this. Like, it's just testing the kind of extremities of what you could be asked in the exams. So the correct answer for this, which less people got, is actually bombesin. So quickly going through the other answers, CA19-9 is the tumor marker most commonly seen in pancreatic cancer, at least for your exams. CA15-3 is breast cancer. Cardioembryonic antigen is present in a lot of cancers, but the main one that we think of it for is for colorectal cancer. Bombesin, as I said, is for small cell lung cancers, also gastric cancers and neuroblastomas, but we'll ignore them for now. And S100 we see predominantly in melanomas. So this was just a little image that I put up as a demonstration of how many tumor markers there are out there and how it is going to be impossible for you guys to memorize all of these for your exam. And as you can see, if you look at this in more detail, the amount of overlap there is with all of these tumor markers is ridiculous. So a lot of them aren't sensitive at all to test for a specific type of malignancy. They're just more to identify the presence of a malignancy. For example, CEA, as you can see, it's in pretty much all of them. So what I have done is I've got a slightly nicer, slightly less image, which has more of the relevant ones you will be required for your exam. I've made a couple of changes to it because there are a couple of errors, I believe, on the image. So lung cancer, you have bombesin, which is for your small cell lung cancers. Breast cancers, you have CEA and HER. Stomach cancers is CEA. As I also mentioned, gastric cancers can be bombesin. Liver AFP, which is actually more associated with testicular, so testicular AFP and beta HCG. Prostate, PSA, as we mentioned before. Colon, colorectal cancer, CEA. Ovarian, CA125 or CEA. Right, question 3. A patient attends your dermatology clinic with the following skin lesion with a long history of sun exposure throughout their life. You ask your consultant, who says it is likely a stage 1 lentigo maligna, what is the first-line management of this condition? So first-line management of this condition is local excision with a 1 to 2 centimeter margin. So back to lentigo maligna. Lentigo maligna is a benign skin lesion. It looks very similar to the superficial spreading malignant melanoma, and it is the precursor of a more serious lentigo malignant melanoma. I know, a bit of a mouthful, which is a rarer form of melanoma and is the malignant form of this condition. It occurs frequently in the faces of older people who have had a long history of sun exposure in their life. And that's kind of how you differentiate it from a malignant melanoma. But again, that's very tough to do, and even dermatologists find it tough to do. They often start out looking like a mole or freckle and then spread relatively quickly from there. With lentigo maligna, because of its high risk of recurrence, which is around 20%, as well as the fact that it can progress into lentigo maligna melanoma, and because it's very tough to distinguish between lentigo maligna and malignant melanoma, it is often treated with surgery. So an excision with a margin of 1 to 2 centimeters, considering it's a stage 1, 1 to 2 centimeters is kind of what we expect. 4 to 5 centimeters on the face is a massive margin, so you wouldn't go for that. There are some cases where surgery wouldn't be appropriate. They will make that abundantly clear in a vignette if that's the case. And if that is the case, then yes, you go for your radiotherapy, chemotherapy, and imiquimod cream. But most of these cases you want to treat with a local excision. So here I just have a couple of images demonstrating some things to do with dermatological surgery. So on the right, you have a diagram showing your lines of Langer on the face. This is just to kind of demonstrate the kind of planes in which surgeons will make their elliptical incisions to encourage like the best healing, the least scar tissue formation, and the least risk of reopening of the scar, just because that's the way your tension lines lie on your face. If you put the scar in line with these lines, it's unlikely to be pulled apart. But if you can imagine it goes across those lines, they're the lines of tension. They're gonna pull your wound apart immediately. The top left is an example of a Mohs staged procedure, which is quite a complex and interesting way that dermatologists actually go about doing a lot of their melanoma surgeries. It involves taking your biopsy, taking the whole bit of malignant tissue out, having a look around the bottom of the area you've incised out. And if you see any area that you're concerned has malignant tissue left over it, sending that next door to the labs. They look at it under the microscope. If there's any further malignant tissue, then you take, as you can potentially see here, another little layer of skin out in that plane where it potentially would have had more malignant tissue, and again send that back to the lab and keep on doing that until they get rid of everything. So here I just have a slide which is showing you, talking you through all the types of melanomas you could possibly ask for in your exam. The main reason why I've gone about doing this is to demonstrate the similarities between your superficial spreading and your lentigo maligna. You can understand looking at these how these are so hard to separate, and why the safest option with these most of the time is literally just to lop them out. And the other ones to point out that you should probably be aware of is this is Hutchinson's sign with acral lentiginous melanoma, and this is amelanonic, so it doesn't have the classical black features of malignant melanoma. Question 4. A 35-year-old man presents to the GP with symptoms of headaches, palpitations, and sweating. He has a known past medical history of neurofibromatosis, and his father previously had pheochromocytoma. What investigation would be best in making a diagnosis? So here, what I'm trying to get at is the most likely diagnosis here is a pheochromocytoma. So it's a rare catecholamine secreting tumor, features of which this is very typical. So the most common features are hypertension, headaches, palpitation, sweating, anxiety. And the other thing to know with pheochromocytoma, which I kind of gave away a little bit in this question, is it's actually got a strong association with neurofibromatosis. So that's one thing to keep in mind for your exams. If you have a patient in a vignette with neurofibromatosis, and there are malignant features, red flag symptoms, weight loss, any of that, or headaches, or any of these pheochromocytoma symptoms, then just remember that there's an association between these two, and they love asking questions about them. Going on to the answers, the 24-hour urine collection of metanephrines, that's the gold standard. That's how we test for it. Just remember that's how you do it, and that's correct. Interestingly, though, ultrasound KUB and CTAP you'd think would be good at diagnosing, or at least showing that there's a mass there. They aren't considered diagnostic because, number one, they're good at identifying a mass but aren't able to make a diagnosis at all. Moreover, issues with pheochromocytomas is around 10% of them are extra-adrenal. So if they were extra-adrenal, they can be in a number of other different locations, and you wouldn't be able to identify them with these scans. I'm going to show you in the next slide where they can be if they are extra-adrenal. Quickly, and then again, ACTH stimulation test is obviously a diagnostic for Addison's, and pituitary bone profile is usually for pituitary adenomas. So here we go. Here's a image of a pheochromocytoma in an adrenal gland. It's not that useful an image. It's just quite, I find it quite nice to actually visualize pathologies when talking about them. It helps me remember them slightly more. And here is a diagram that I found about paragangliomas. Paraganglioma literally just meaning a tumor near the ganglionic chain. So that's not overly helpful. But these paragangliomas are very commonly pheochromocytomas. And as you can potentially see down here, this is what's called the organ of Zuckerland, and it's just adjacent to your bifurcation of your aorta, and that is the most common location for extra-adrenal sites of pheochromocytomas. Question 5. The following is a knee x-ray from a 30-year-old woman. The lesion you see is benign, locally aggressive, and diagnosis is made by identifying mononuclear stromal cells resembling interstitial fibroblasts on biopsy. What is the most likely diagnosis? So most likely diagnosis here is a giant cell tumor. So the reason why I put the histological words in there is just so you could read them and kind of remember the association between those words and giant cell tumor. So if you ever were to see those words in a vignette again, you'd think, I remember that, that's giant cell tumor. The way I like to think of bone tumors, bone cancers, is to split them up into benign and malignant. The diagram I have here splits them slightly differently. It splits them into over 30 and under 30, but I think it has too many cancers for you to remember, too many cancers that you need to remember. So it's better to split it into 3 for benign and 3 for malignant. Starting with malignant, it's really easy. These are all the sarcomas. So you have your osteosarcoma, bone sarcoma, chondrosarcoma, cartilage sarcoma, and a Ewing sarcoma, which is just the other one. Osteosarcomas are the most common primary bone tumors, which occur in the metaphysis of long bones in kids and adolescents. Chondrosarcomas are the malignant tumors you get in middle-aged people, and they're of the cartilage. Ewing sarcoma is the other malignant cancer you get in kids, and the one that differentiates it is it's the one on an x-ray that looks like layers of an onion. And then onto your benign bone tumors, you have your osteoma, sorry, which is typically in the skull, and it's seen in Gardner syndrome. You also have osteochondroma, which is the most common kind of benign bone tumor, and it's classically called a cartilage capped projection. And finally, you have what I have said, the giant cell tumors. So it doesn't have sarcoma in it, so you know it's not malignant, and it's giant, and that's a pretty damn good description of what it is. So it is a benign but very locally aggressive tumor, most common in distal femur and proximal tibia. 30 to 40-year-olds most commonly affected, insidious onset, and they can present with kind of fractures, pain during activity, or pain at night. Treatment for them is often reconstructive, because as I'll show you in my next couple of images, they can be really locally invasive and destructive of the normal bony tissue. So for example, this is one in the hand that I found. So look at the size of that. As you can imagine, quite a lot of reconstructive surgery is required to return the functional status of that finger. Okay, question 6. What is the most likely diagnosis in this chest x-ray given the lesion is a primary cancer? Again, I'm slightly mean with this one. The most likely diagnosis, it's a very tough chest x-ray to view. Personally, for a long time, I can see anything in this chest x-ray. But it's a chest x-ray directly from Radiopedia talking about adenocarcinomas. So what I was testing more was just reading the vignette. Given that it's a chest x-ray, what is the most likely primary lung cancer? The answer to that is adenocarcinoma. They make up about 30% of total lung cancers, 35% to 40%, with the next most common being squamous and closely followed by small cell lung cancer. Those are kind of the main ones. So adenocarcinoma is the most common one. It's found more commonly in women, and as you can see from her breast tissue, this is also a female. This is also a female chest X-ray. It is the most common lung cancer in non-smokers. I see a lot of people get this wrong. It doesn't mean that smokers don't get this. It's just if you have a non-smoker with lung cancer, it is almost certainly this. Still, most people that get this cancer are smokers. So the other non-small cell lung cancer you have that's quite common is your squamous cell lung cancer, strongly associated with smoking, often cavitates and has a poor prognosis. You have large cell carcinoma as well, which is the least common. We don't talk about it very much. It's the one that's seen very peripheral and is always found quite large. And finally, you have your small cell lung cancers, which are almost always seen in smokers. They're often caught really late, so they're already metastasized and they've got a pretty bad prognosis. And they are often cause of a lot of paraneoplastic syndromes, which I'll discuss in the next couple of slides. So just because this chest X-ray was quite tough, I've added the CV from Radiopedia as well from the same patient, which it's much easier to locate the lesion in this one. So here is more just for you looking back over the slides at a later date, but this goes through all of the information I feel like you need to know about lung cancers. So the associations are always really important. They love testing that in medical school finals. So small cell lung cancer is the one that's associated with all of these paraneoplastic syndromes. So it can release ADH, ACTH causing SIADH, Cushing's, Lambert-Eaton syndrome as well, which is, as Leslie lovely put it yesterday, is kind of like the opposite autoimmune condition to myasthenia gravis. You have twitches that get progressively worse and worse. It's to do with an autoimmune presynaptically of calcium channels, basically. And yeah, as it says, very poor prognosis with Mets in 70% of the presentations, which is really bad. Squamous cells also have paraneoplastics. It tends to be more pituitary hormone releasing proteins, causing your classic hypercalcemia symptoms, which you can look up in your free time, but it's the stones, groans, moans, and psychiatric groans. Finally, adenocarcinoma. The other thing to remember, the association with that is the pancreas tumor, which is the one you find up in the apex of the lung. These often are hidden behind the clavicle and some of the bony features up there, so they're harder to locate, but they're really important. Recently, I heard of one at my GP who that got missed for a long, long time and ended up only being found when it was very late stage. So it was quite a tragic story. Also, with these pancreas tumors, they can be associated with Horner syndrome and superior vena cava obstruction, so they're important not to miss. Question 7. A 60-year-old female patient is brought into A&E in cardiac arrest and unfortunately dies as a result. Her family says she's recently been complaining of weakness that worsens after activity and improves at rest, as well as weakness and drooping of some of her facial muscles. During an autopsy, it was noted that the arrest was secondary to a tamponade. What else is a likely finding on the autopsy? So again, this is a pretty tough question. I gave a little bit of a hint as to it, the question before. It's basically to do with your identification of not only one condition, but an associated condition. But again, I feel like that's the kind of thing they love testing in these exams. So remembering these associations is really crucial. So what I'm talking about here is her family have been complaining of symptoms of weakness that worsens with activity and improves at rest. These are kind of symptoms which are classical of myasthenia gravis. As I mentioned, the opposite of Lambert-Eaton before. So it's a autoimmune neuromuscular disease, basically. And the thing to recognize with that is myasthenia gravis is very heavily associated with thymomas. So linking those two together is a great way to kind of get yourself to the right answer in this question. Irrespective of that, looking at the cause of death and the autopsy, thymomas are the most common anterior mediastinal tumors. Usually they're slow growing incidental findings and you don't really do anything about them. But in a small number of cases, they can grow big enough to cause airway obstruction or cardiac tamponade. The other answers I have in here, so cardiac sarcoma, well, less cardiac sarcoma and mesothelioma. Not sure cardiac sarcoma is a thing. Mesothelioma is a lung cancer, obviously, or a lining of the lung. So less likely to cause cardiac tamponade, but Hodgkin's lymphoma and germ cell tumors are both other forms of anterior mediastinal tumors, so could theoretically cause a tamponade. So this is just a demonstration of how large these thymomas can get. As you can see in the CT scan, it's massive in the anterior mediastinum and crushing down into all four cavities of the heart, and obviously these are what cause the tamponades. Right, question 8. A 42-year-old woman presents in GP with perianal pain, perianal bleeding, and fecal incontinence. On digital examination, a palpable lesion is identified. You feel this is likely an anal cancer. What is the most important risk factor for anal cancer? So, looking here, the most important risk factor is an HPV-16 infection. So, anal cancers, the most often thing you get asked about these is either when to do a 2-week rate referral, which if you ever have a hard palpable mass on your like anus, which isn't soft and spongy and bleeds, which makes you more think hemorrhoids, you always refer them 2-week wait. The other thing you'll get asked about anal tumors is risk factors, and risk factors is the main one is an HPV infection, either 16 or 18, but these are the cause of 85% of anal cancers. The other ones, all of these are actually other ones apart from HPV-6. That was just to throw you off. But history of anal intercourse, history of CIN, MSN, immunosuppressants, and smoking are all risk factors for anal cancer. So looking at the history of this patient is also very classical of anal cancer as well. Question 9. An 80-year-old lady presents in GP with non-specific symptoms of some weight loss and bruising. Blood's taken up the following results. What features would be visible on a blood film? So everyone did very well on this, I seem to remember. So the most likely answer here is going to be E, smudge cells. And that's because the most likely diagnosis is CLL, chronic lymphocytic leukemia. So you have symptoms of very non-specific, vague red flag symptoms, weight loss and bruising. Alongside this, you have blood results which show kind of a frank lymphocytosis, along with like pancytopenia of all of the other blood cells. So you have low HB, low platelets, because you're getting such overproliferation of lymphocytes, you get suppression of all the other blood cells. And of all of the answers present, the most likely to be visible on a blood film is either a smudge or a smear cell, which are used in the diagnosis of CLL. So generally for CLL, our management is either, depending on, because it's often presents in older people and it's an incidental finding, often they're not treated, but if they are treated, they're treated with chemotherapy agents. Going through the other cells, we have, so smudge smear cells, I guess you can see from there, they kind of look smudge and smeary. So easy to remember-ish there. Stomatocytes, I believe, are sometimes called cat's eye cells, which I guess you can kind of see with that. And they're seen often in congenital or acquired hemolytic anemia. The teardrop red cells, I believe, are to do with splenic abnormalities, which lead to bone marrow fibrosis. Acanthocytes, like hedgehog cells, are seen in end-stage liver disease, and schistocytes, or red blood cell fragments, as you can see here, are seen in thrombotic microangiopathy. Question 10. A 50-year-old man has presented with dyspepsia and vomiting. He is investigated with endoscopy, which shows a suspicious lesion, which is biopsies. Biopsies in cultures have shown a low-grade localized gastric malt lymphoma, H. pylori positive. What is the most appropriate treatment in this case? I seem to remember pretty much everyone got this right. Interestingly, I always get this one wrong because I think it's a lymphoma. I think it's a malignancy. You're going to need some sort of some more invasive treatment than just eradication therapy. But eradication therapy is actually the correct answer. As I kind of alluded to earlier, gastric cancers are a pretty nasty cancer. They often present with pretty non-specific symptoms. They're often found quite late. So they often present with the classic dyspepsia, dysphagia, early satiety, vomiting, melena, nausea, and then other red flag symptoms of weight loss, night sweats, anorexia. This is often the case, apart from malt lymphomas, which actually have a pretty good prognosis as long as they're caught in a slightly earlier stage, which often they are more so. And because 95% of malt lymphomas are associated with an H. pylori infection, generally when that H. pylori infection is effectively treated with this regime, the malt lymphoma will sort itself out. If it's a high grade malt lymphoma, then they do tend to require radiotherapy and surgery as well, which is why I specified that it was a lower grade. These are just images that it'd be good for you guys to remember. As I said, gastric cancers are often found quite late. So when you see OGD photos of them, they look quite nasty, fungating masses, whereas malt lymphomas are much more mild. They're much more harder to visualize on an OGD. So if you see that, it's more likely to be a malt lymphoma than another form of gastric cancer. Right, question 11. 45-year-old lady presents to your GP clinic with features of a recent chest infection, productive cough, fevers, etc. She also mentions that a month ago she noticed a solid, painful lump in her armpit. What investigations would you like to organize for this patient? So the correct answer here is an urgent triple assessment. So what I was trying to do in this question was distract you with the chest infection symptoms. What you have here is a over 30-year-old lady with an unexplained lump in her armpit. And that is one of the tick box factors that makes you go urgent triple assessment. So the other things that immediately get you to go for an urgent triple assessment is being over the age of 50 with unilateral nipple changes, any breast skin changes, or previous cancer with suspicious new symptoms. Criteria for non-urgent referral for triple assessment is being aged less than 30 with an unexplained breast lump. So quickly, what is triple therapy? Number one, history and examination. Number two, histology and cytology. So that's either with a fine needle aspiration or a core biopsy. Number three is imaging. So that's either with a mammogram or ultrasound. Generally, mammograms are used on women over the age of 40 and ultrasounds are used in women under the age of 40 due to density of breast tissue. Added this in just as a bit of good news about medicine at the moment. As I'm sure everyone is aware, there's a lot of bad news circulating around the NHS and how we're doing in hospitals, etc. But breast cancer screening in particular has been a particular highlight of care in the UK. This poster demonstrates that, what is it, 5 women out of 1,000 are saved from death as a result of this screening process, which is a phenomenal hit rate for a screening regime. And a 17 overdiagnosed patients is also a pretty good hit rate considering other screening tests like PSA, which have a massive overdiagnosis rate. I've also attached in the comments of this slide a good article about how successful triple assessment has been in correctly diagnosing breast cancer, if anyone was interested in reading it. Question 12. A 30-year-old man with known Burkitt's lymphoma is due to start his first round of chemotherapy. Just prior to it, he's given a course of prednisolone, and a few days later, he is brought in following a spontaneous seizure with no history of epilepsy and soon arrests. Some bloods were taken when he attended A&E. What is least likely to be seen on these bloods? Again, this is a pretty mean question. I'm testing the more niche knowledge of tumor lysis syndrome, which I hope you could recognize. And the correct answer here is hypokalemia. So again, just going to the basics, this is, you'd like to think tumor lysis syndrome here because you have someone who's been newly diagnosed with a large cancer, so Burkitt's lymphoma, they're one of the larger cancers, more proliferative and chemosensitive cancers. And what happens is usually what happens is when these patients are started on their first round of chemotherapy, it breaks down loads of the cancer cells, causing a massive release of all of these electrolytes into the bloodstream, causing massive issues of AKIs, electrolyte imbalances, seizures, and cardiac arrhythmias and sudden death. So the way that you diagnose TLC in a laboratory is the presence of an AKI, so AKI or D, increased serum creatinine, pretty much the same thing, hyperphosphatemia, hyperkalemia, and hypocalcemia. So the odd one out there is the hypokalemia, where it should be hyperkalemia, which is released by the cells when the tumor lysis syndrome happens. One thing to mention that got mentioned by Lizzie is it is hypokalemia, not hyperkalemia, because hypokalemia is co-transported out renally with phosphate. Okay. 13. A 5-year-old baby is brought into your GP practice by his parents. They say that over the last 6 months, he has been very weak, tired, and has lost some weight. He's also been getting recurrent chest infections and has been developing bruises all over his body. What is the most likely diagnosis? So the most likely diagnosis that I hope you could identify here is ALL. So symptoms of ALL are usually, you see them in young kids. They feel weak, tired, very vague symptoms, flu-like symptoms, unable to shift, infections, weight loss, bruising, and swelling of lymph nodes. So we have a lot of red flag symptoms, and then you look at the bloods, you have a pancytopenia in red blood cells, and I don't have platelets in here, but you can kind of assume that they've been suppressed as well as a massive increase in lymphocytes, which is kind of indicative of an ALL. So just going on here, talking quickly about the blood cancers, the leukemias, going through the 4 of them and how to remember them. I always like to think back to the actual development of blood stem cells. So the A's, the acute leukemias, they occur in the younger stages of blood cell development. And funnily enough, the way to remember is they happen at the young stage of blood cell development. They also happen more in young patients. So ALL is the common one that is seen in kids. AML is seen in adults, but it's more adults, whereas CLL and CML are seen in older patients, like elderly patients. So AML is the most common kind of leukemia in patients. CLL, as we discussed earlier, is often found in older people, incidentally. and is the one that you can remember. It has a Richter transformation into a lymphoma. CML is the one that is seen in 60 to 70-year-olds and is the one associated with the Philadelphia chromosome, which is seen in 95%. And ALL, as we just discussed, is seen in young patients with very vague symptoms. It's actually a overproliferation of lymphoblast cells. So weirdly, sometimes with the bloods, lymphocytes can be normal because it's a precursor to lymphocytes rather than the lymphocytes themselves. So you could have suppressed lymphocytes and like raised monophils, but they would be very mean to do that to you. Okay, question 14. 60-year-old man presents to your clinic with symptoms of weak or intermittent urinary flow, nocturia, and post-micturition dribbling. On initial testing, it's decided he has benign prostate hyperplasia, BPH. What is the first-line management in this condition? So very well done to 95% of the people that got this right. The most likely answer here is tamsulosin. So he's already been tested and it's been decided he has BPH. He's symptomatic of BPH and he's wanting treatment. So a watch and wait. Whilst that is also, it could be an acceptable management in this condition, you're most likely to try and treat it medically. And the first line medical management for BPH is either giving them a alpha-1 antagonist like tamsulosin or a 5-alpha reductase inhibitor like finasteride. Second to that, you can do combination therapy of the both, which is B, with alfuzosin being another alpha-1 antagonist. Transurethral resection of prostate, so a TURP, that is generally your last resort with BPH and is used for patients who have recurrent urinary retention causing pyelonephritis or, back pressure into the kidneys. Guserelin is a synthetic GnRH agonist, which is used in the hormonal therapy of prostate cancers. So it's just another drug you may be aware of. Final question, almost done. So a healthy 60-year-old woman attends your dermatology clinic with a flat plaque with a yellow warty surface on her nose. She is unsure how long it has been there and says it is non-painful. Which is the most appropriate first-line management? So the correct answer here, which I think most people got right, is fluorouracil cream. So personally, I feel, especially with, this is actinic keratosis, by the way, but you gauge that best from the vignette than you do from the photos, because I find in dermatology, in particular with actinic keratosis, that all of these images end up looking exactly the same or totally different, and it's really hard to identify it just based on the photo. So with actinic keratosis, you come to this diagnosis based on the description of a flat or thickened plaque with a scaly or warty surface. On top of this is a 60-year-old woman with the lesion in a sun-exposed area, and it doesn't look like a melanoma. So that's how you go down the line of actinic keratosis. And the management for actinic keratosis is as follows. So you give all of them conservative advice of sun avoidance and sun cream. And then the first line management for these patients is the fluorouracil cream, which is generally a 2 to 3 week course. It's the classic one where you give it to them and then within a week, their whole skin has gone red and sore and everything, because it's like burning away the first layer of skin, getting rid of this lesion. And then once they're finished with this course and when it heals back, the lesion is gone. Because it gets so red and sore and inflamed, you can also give them hydrocortisone cream to manage that slightly. The second line is topical diclofenac. Third line is your other imiquimod cream, which is now being licensed under the BNF. And then failing that, you can go for your curettage, cautery, cryotherapy, which are the other options that have been mentioned here. I've just put this final slide up here to kind of illustrate the different photos of actinic keratosis. These are all photos from DermNet, so a brilliant dermatology website, which almost all the dermatologists use for their photos when giving dermatology tutorials. And even their own website has these 3 photos of actinic keratosis, and they all look totally bloody different. So I'd be very impressed if you could identify these as actinic keratoses based purely on the images. I'd focus more on the vignettes in these cases. Perfect. So that's that. Thank you again for coming. I'm sorry this wasn't the recording from the actual session, but this was the best we could do given circumstances. I hope you found it useful. Please feel free to leave feedback if you can. Although most people receiving this already would have given their feedback. Anyway, thank you for coming, and hopefully we'll see you next week.